As a gastroenterologist, dealing with a forced non-medical switch is likely to be a significant impediment to my therapeutic relationship with my patient. I actually find it very concerning, and particularly if it is enforced without an appropriate backup strategy. For medical or for non-medical switching, it's a particular challenge because these are patients who have often been on biological therapy for long periods of time, and this has produced an improvement in their quality of life and health, which they really value. And it has removed from them the fears and concerns about disease flares. And to have an external organization impose a switch without consultation with the patient and physician, I think has firstly the potential to lead to major stress and anxiety on the patient's part, because it will raise the fear that their disease will flare up in a way that they have no control of. It makes it really difficult for the physician because they're not sure what they should be monitoring for. And in the absence of a follow-up strategy, it's not at all clear how one manages or helps patients who've had a disease flare after an enforced switch. The data and the recent evidence-based position statement from Crohn's Colitis Canada and the Canadian Association of Gastroenterology actually recommends against a non-medical switch. And the reason for this is that the data that we have actually show that there is an increased risk of disease worsening or a need to switch treatment after a switch from an originator molecule to a biosimilar. So I think all of that being put together, I think this is a major concern for gastroenterologists, for their patients, and for their combined efforts to try and treat what is really a chronic and debilitating illness for which we now have good treatments. I believe that patient-doctor choice is really important because as physicians, our commitment and our responsibility is to the individual patient. And so when we're trying to help individuals, when we're trying to help patients, this is not just about giving medication or telling patients what to do, it's working with them to try and optimize their care. And that's really based on a relationship of trust. It's trust on the patient's part that I'm going to do the best for them as individuals. And it's based on me trusting my patient that they're going to be able to follow through with the advice and the recommendations that I make. And anything which interferes with that runs the risk of compromising healthcare for those patients.